problem, I will. I'm ready to start if we're ready.
Please, you can go ahead. You're the one we are waiting for. Thank you.
So, good evening, everybody, coordinators, and all our chiefs and profs. I'm Dr. Asore Emmanuel. I'm an SRO in FMC Asababu, presently doing my posting at UVTH. So I'll be taking acute coronary syndrome, as advertised earlier. I think I have close to 100 slides, so I'll try to be as fast as possible. So this is my outline I'll be going through. So the clinical presentation of acute coronary syndrome is broad. So acute coronary syndromes tend to stem from coronary artery disease, from stable angina to acute coronary syndrome, where we have the broad classification of unstable angina and STEMI and STEMI. So this syndrome of acute coronary syndrome, it ranges from cardiac arrest, electrical or hemodynamic instability with cardiogenic shock, to ongoing ischemia or mechanical complications, patients who may even present to us when they are pain-free. Acute coronary syndrome is when occlusion of one or more of the coronary arteries occur, usually following plaque rupture, resulting in decreased oxygen supply to the heart muscles and death of cardiac myocytes in the region supplied by that particular artery. The leading symptom initiating the diagnostic and therapeutic cascade in patients with suspected ACS is acute chest discomfort, described usually as a pain or pressure or tightness and burning. Chest pain equivalent symptom may also occur, which some patients will present with atypical symptoms as I'll mention later. Some atypical symptoms like epigastric pain radiating to other areas like the chest, like the arm, the left shoulder, the jaw, the back. Generally, coronary artery disease is divided into stable angina and acute coronary syndrome, as I mentioned earlier, with acute coronary syndrome being further divided into unstable angina and myocardial and STEMI and non-STEM and NSTEMI. In classic patients that have coronary artery disease, they present with the classic symptom of cardiac pain or chest pain. If those pain are present only with exertion, they are most of them are the classic pain is retrosternal, and those classic radiation areas like to the left arm, the shoulders, and so on. And they present only exertion, or when the pain comes relieved by giving GTN, those are usually on the spectrum of stable angina. But once the pain starts presenting at rest, those pains are usually to the spectrum of the acute coronary syndrome. So this next slide is just a pictorial representation of what happens actually in patients with coronary artery disease. To the left of the slide is a stable angina, where we just see the development of arteriosclerosis narrowing the lumen of the vessel. But on the other side, where the spectrum of acute coronary syndrome, you see thrombus formation already occluding the part of the lumen. And on the extreme, you see the thrombus completely occluding the lumen of the vessel. This is how we now differentiate between the unstable angina and NSTEMI and STEMI. In STEMI, classically, the thrombus has completely occluded the vessel. But in NSTEMI and unstable angina, there's partial occlusion. But how to now subdivide or differentiate between unstable angina and NSTEMI is doing cardiac enzymes. So when you do cardiac enzyme, when cardiac enzymes are elevated, it is tending towards an NSTEMI. But when cardiac enzymes are negative, that means we're limited to unstable angina. So this is the universal definition of myocardial infarction, said to be defined as cardiomyocyte necrosis in a clinical setting consistent with acute myocardial infarction. A combination of criteria is required to meet the diagnosis of acute myocardial infarction, namely the detection of an increase or a decrease in cardiac biomarker with at least one value above the 99th percentile of the upper reference limit, with at least one of the following. One, the symptom of myocardial ischemia, which is the classic chest pain that the patient presents with, new ischemic ECG changes like the ST segment elevation and other ECG changes, development of pathologic T wave on the ECG. When you do an imaging, as evidence of loss of viable myocardium or regional wall motion abnormality. Then when you do an angio, you see an intracoronary thrombus. Once you have one of these together with the previous read criteria, that's the classic acute myocardial infarction diagnosis. So this is just a pictorial representation of what I said earlier: acute coronary syndrome, the division into ST segment elevation, ST. When the cardiac enzyme is positive, it tends towards ischemia or ischemia. When negative, unstable angina. On the epidemiology, she said that each year worldwide, over 4 million patients are admitted with unstable angina and acute MI. Every 25 seconds, an American will have a coronary event, and about 500,000 deaths in the US annually in patients presenting with chest pain, while greater than 900,000 patients undergo percutaneous transluminal coronary angioplasty with or without system. This is the largest cause of death in the United States, with over 1 million people having myocardial infarction per year, and almost half is fatal. Majority of the mortality is said to be associated with STEMI. In Nigeria, of course, there's paucity of data. In a cross-section study of standalone PCI in a Nigeria Cardiac Catheterization Lab published in 2014 by Deyemi Johnson et al., showed that out of 1 2 patients referred for clinical disease, about 8 were confirmed to have coronary artery disease. For the risk factors, as we all know, they are divided into modifiable and non-modifiable. For the modifiable, elevated blood pressure, which patients usually have, and they increase with age. That is one of the major modifiable risk factors. Hyperlipidemia, smoking, which is vasculotoxic and injures the endothelial lining, physical inactivity, obesity, DM, unhealthy diet, low socioeconomic status, which exposes people to all kinds of risky lifestyle, mental health like depression, psychosocial stress, alcohol, drugs, excess homocysteine, elevated inflammatory markers, and abnormal blood coagulation. While for the non-modifiable, age is a major risk, which is non-modifiable, and this condition is prevalent with increasing age, medical gender, race and ethnicity, hereditary, family history. This is a pictorial representation of the coronary circulation, because for us to understand acute coronary syndrome, we must understand the coronary circulation, and part of the heart is vessel supply. So majorly, it is the right and left coronary artery that are involved in that supplies the heart, and these two vessels. Hello.
Sorry for interrupting you. I think probably you might need to readjust your mic. Your audio was good initially, but now we can hardly hear you, and it's not good for the recording. Thank you.
Okay, sorry about that. Nothing changed. Maybe it's the network. I'll try to increase my voice more. Thank you. So understanding the coronary circulation, the heart is supplied by the right and the left coronary vessels or coronary artery. Both of them stem from the aorta. And the right comes out just from the right coronary sinus, crosses the right coronary artery, it crosses through the right atrioventricular groove, supplies the right atrium, supplies the right ventricle, goes down and transforms into the posterior descending, which goes posteriorly and supplies the posterior part of the heart, majorly the intraventricular septum, posterior part of the interventricular septum, and also the posterior wall of the left ventricle. Those are the major supplies. While the left coronary artery, the left stem, it comes from the left coronary sinus. Immediately it comes from the left coronary sinus, about 2.5 centimeters. After that, it divides into the left circumflex and also the left anterior descending. The left anterior descending passes through the anterior part of the interventricular septum, supplying the septum, the anterior part of the septum, and majorly supplying the anterior part of the left ventricle, while the left circumflex supplies mainly the left ventricle and the left atrium. So if we understand this and follow, we may now understand the representation of the ECGs. So this is just a slide just to show what I've said. The right coronary sinus, that's where the right coronary artery stems from. Left coronary sinus, that's where the left stems from. The right coronary artery continues at the posterior descending, while the right coronary artery is of note. It should be noted that the right coronary artery supplies the SC node and AV node. That's why in patients that have right coronary artery occlusion, most of them they usually present with bradycardia and AV blocks because of their supplies. For the pathophysiology, the pathophysiology stems around coronary atherosclerosis. That's why most of the management still goes around statins and platelets. They must be part of the secondary prevention. So atherosclerosis is a progressive degenerative disease in which plaques containing cholesterol, macrophages, and smooth muscle cells, they build up in the walls of the medium-sized to large epicardial arteries, causing narrowing of the blood vessels and decreased blood flow. The atherogenic process is characterized by dysfunction of the endothelial lining, inflammation of the vascular cells, buildup of lipid and cholesterol and inflammatory cells in the vessels, with accumulation of debris within the intima and the subintima. This process, when there's dysfunction of the endothelial lining by the risk factors we mentioned earlier, like smoking, diabetes, hypertension, because the endothelial lining of the vessels, it contributes to the integrity of the vessel. So when they are distorted, that is the first injury, that's the first process that occurs that builds up to the plaque formation. So that pulls up macrophages, there pulls up lipids, forming foam cells. Those foam cells with time pulls up more lipid, and with time it causes generation of the plaque. And those plaque with further injuries, both deep and superficial injuries, causes formation of thrombus. And these thrombus may grow into the lumen and block and occlude the lumen. So as I said, this plaque rupture believed to be the triggering mechanism for the development of the thrombus. When the plaques rupture, a thrombus is formed at the site that can occlude the blood vessel, thus resulting in myocardial infarction. So this slide just represents the pictorial representation of what I said earlier: plaque formation, with the core of the plaque being that of lipid, comprised of lipid and smooth muscle cells, lipid smooth muscle cells, and macrophages. This is another pictorial evidence. When we share the slide, we'll tend to understand all this: the plaque formation, narrowing the blood vessels, causing thrombus formation. Those thrombus formation causes release of cytokines that activate platelets, causes platelet aggregation, and causes thrombus formation when there's further injury, narrowing the lumen further. So within 24 hours, leukocytes infiltrate the cells of the within 24 hours, leukocytes infiltrate the area of the cell death. Enzymes are released from the dead cardiac cells. Proteolytic enzymes of neutrophil and macrophages remove all the necrotic tissue by the second and third day. Development of collateral circulation improves area of those poor perfusion. By the 6th week after myocardial infarction, scar tissue are replaced by necrotic tissue. In an attempt to compensate for the infarcted muscle, the normal myocardium will hypertrophy and dilate. The shorter the time between coronary occlusion and reperfusion, the greater the amount of myocardial tissue that will be salvaged. So you should understand that during the treatment, this is where it comes from when they say time is muscle. An irreversible damage to the myocardium can begin as early as 20 to 30 minutes after interruption of the blood flow. The dynamic process of infarction may not be completed, however, for several hours. For the clinical feature of acute coronary syndrome, the main clinical feature is classic chest pain, cardiac pain, which is said to be most of the time retrosternal on the left, radiate to the left shoulder, the arm, the neck, the back. And some patients may also present with other symptoms like shortness of breath, cough, lightheadedness, fainting spells, nausea and vomiting, sweating, which may be profuse due to excess sympathetic drive. Some patients may present with atypical features like indigestion, unusual location of the pain. Some pain can just be epigastric and that may confuse some clinicians when patients present with epigastric pain and they feel it's maybe gastritis or PUD. Index of suspicion should be higher when any patient with this certain risk factor presents with epigastric pain. The signs some of these patients present with respiratory distress, diaphoresis, hypotension, depending on the area of the vessels involved and the area supplied, tachycardia, bradycardia, as we said earlier, if it's the right coronary artery supply, which supplies the AV node. Some present with hypertension, murmurs if there are complications involving the mitral valve. Some start presenting with heart failure from complications. They also present with STRS for raised JVP and rails. For patients with ACS, the workup, the first most important investigation we must do for them when they present to us within minutes is ECG. With ECG, it will help us either strengthen our diagnosis of acute coronary syndrome or look for the alternative diagnosis, because so many conditions also present with chest pain. So not all chest pain are acute coronary syndrome. So we must do an ECG to strengthen our diagnosis. Cardiac biomarkers are one of also the key investigations that should be done. In fact, it should be a point of care investigation, but funny enough, in most centers, it's a luxurious test. So when some people in some centers see cardiac biomarkers, they are being lucky to even have it. Those are the challenges we have in this part of the world. Full blood count, EU creatinine, lipid profile, protein profile, then 2D echo, and angiography. What are the importance of doing an ECG for patients? As I said earlier, to confirm diagnosis of acute coronary syndrome. Acute coronary syndrome, as we said earlier, could be ST segment elevation or non-ST segment elevation, but suffice us to also know that a normal ECG does not preclude preclude a STEMI, but an ECG is very important in them. ECG will also help us identify location and size of the infarct, because the location, as we said, based on our ECG representation, I'll show you a slide later to depict, for us to understand those locations that are affected on the ECG. Like the precordial lead and the limb lead, the precordial lead V1, V2, V3, V4, which are the anteroceptor, to help us also depict which arterial territory is being affected. Like, for example, if it's the anterior, from V1 to V4, which is anteroceptor, most of the left anterior descending supplies those areas. So if we have a marked ST segment elevation on those areas, it will give us an high index of suspicion that it may be a large infarct, because that is likely that's the anterior part of the heart that is being affected, the left ventricle. Also, it can also identify the time of the infarct, because when a patient presents with a classic chest pain, now we do an ECG. The timing of the ECG, the timing of the chest pain comes with different representation. Like in the first 4 hours, 3 to 4 hours, when we see an hyperacute T wave, we know it's okay. The patient presents with a classic chest pain of ECG of acute coronary syndrome. With hyperacute T wave, that gives us an index of suspicion that the chest pain or the event just started. So hyperacute T wave starts first, followed by, after some hours, ST segment elevation now shows up, then T wave inversion, then Q wave. So it's an evolution in the pattern of the ECG. So it helps us in doing that. And also it can help us monitor outcome of treatment, because with treatments, we expect that we do serial ECG, then this ST segment elevation or the changes can now reverse to normal. So these are typical ECG changes in STEMI. On the anterior part of to the left is the infarct site, and on the right is the representation of on the ECG. These are things we are familiar with. The anterior infarct, most of it's represented on the ECG by V3, V4 anteroceptor, V1 to V3 anterolateral. 451 AVL lateral, which is the high lateral 1 and AVL, inferior 2-3 AVF, posterior. The reciprocal changes on V1, V2. Then, as I said earlier, the coronary artery representation on the heart and the ECG changes. In LAD, the left anterior descending, which is one of the branches from the left main coronary, supplies the anteroseptal. The right coronary artery supplies the inferior. The high lateral is supplied by the first diagonal branch of the LAD, and then the posterior part of the heart is like most of the time is largely supplied by the right coronary and also by the left circumflex. This is an ECG of a patient here in a UBTH some years ago. If you look at the inferior leads, which are the 2-3 AVF, you see a marked ST segment elevation with reciprocal change ST segment depression on the high lateral leads.
Hello, hello, sorry, Dr. Asore. If you are a co-host, you should mute anybody that is having background noise. That's why the co-host. Thank you. Sorry, Asore, you can go ahead. Sorry.
Okay, thank you. This other slide is also a patient in UBTH taken some years ago, showing anteroseptal ST segment elevation. This is marked in V2 to V6 with with also lead 1 and AVL. It's a classic ST segment elevation on the anteroseptal and lateral leads. Well, as I mentioned earlier, not all patients present with a normal ECG. When I say normal, I mean not all patients that present with ECG that are not ST segment elevation that we won't have that index of suspicion that they may have ST segment elevation MI, because there are some equivalent things we see on the ECG that stems us towards ST segment elevation MI. Like there are some signs like the winter sign, which shows is a sign of an occlusion of the left anterior descending, and the following are things we see that will stem us towards ST segment elevation MI, even if on the ECG there are no classic ST segment elevation MI. So when we see things like upsloping ST segment depression of greater than 1 millimeter in the precordial leads, prominent T wave, and they should be symmetrical on the precordial lead. As I said, as of importance is the absence of ST segment elevation in the precordial lead, and there should be reciprocal ST segment elevation in the AVR. AVR is one of the lead we most of the time don't actually look at. But when we see this kind of signs on an ECG, it stems us towards an ST segment elevation MI, even if on the ECG, the patient does not have a classic ST segment elevation MI. So this is an ECG that shows the winter sign. If we look closely, you see it's an ST segment depression on the precordial leads, V1, 2, 3. It's classical with a very tall T waves, and they are symmetrical, as I said. And if we also look closely at V1, AVR, there's a slight ST segment elevation, about 0.5 millivolts. Acute hyperacute T wave. Hyperacute T wave, as I said earlier, is the first sign of an ST segment elevation MI, and it happens immediately after the chest pain. It's the first thing we see on an ECG. So if the patient presents within few hours, say 2 to 3 hours, the patient may present with just hyperacute T wave, and we may start thinking we should also put a STEMI as one of the major thing on our mind as we're looking at other causes of hyperacute T waves. But the classic representation of hyperacute T wave that will stem us towards STEMI, it's the height of the ST segment, height of the T wave, and the T waves are classically not symmetrical. They are usually asymmetrical on the precordial leads, unlike the De Winter sign where it's usually symmetrical. For hyperacute T wave that depicts or that links us towards the STEMI, they are usually asymmetrical. Okay, then some patients, there are some criteria, some school of thought that says if a patient presents with a new left bundle branch block or presumably new left bundle branch block, that leads our mind towards a STEMI, so manage a STEMI. But also remember that there are some also school of thought, like the American Heart Association has kept that aside because we can't use it. They believe that you can't use the incidence of patients that they've actually studied that have left bundle branch block that don't have STEMI, they are high. The incidence is low, sorry. So they've kept that beside and introduced this Gabusa criteria to help us think of a STEMI rather if a patient have a left bundle branch block. So the criteria, the Gabusa criteria, there are three. The first is a concordant ST segment. If you see a patient with left bundle, an ECG with a patient with left bundle branch block, look at the following things. Once you see them, it is likely a STEMI equivalent we are dealing with. One, a concordant ST segment elevation greater than 1 millimeter in leads with a positive KRS complex. Let me just explain what they mean by concordant and discordant. Concordant simply means that the ST segment, if it is ST segment elevation, the QRS complex will be positive. So they are moving in the same direction. And if it is ST segment depression, the QRS complex, the deflection or the amplitude of the QRS complex will be deeply negative. So both of them are moving in the same direction. But a discordant ST segment elevation, ST segment depression is when the ST segment, for example, when it says discordant, the elevation is moving like an ST segment is up, while the QRS complex is negative, so it's down. So that's discordant. They are moving in the opposite direction. So for the Gabusa criteria, there's a concordant ST segment elevation greater than 1 millimeter and leads to a positive QRS complex. You give a score of 5. A concordant ST segment depression greater than 1 in leads, V1 to V3, not V1 to V3. You give a score of 3. Then an excessive discordant ST segment elevation greater than 5, you give a score of 2. Once a patient meets 3 or above, if a patient meets a score of 3 and above, it is likely to this patient having an STEMI. But there's also a reviewed Gabusa criteria, which is called the Smith modified Gabusa criteria. But that is just the excessive discordant ST segment elevation greater than 5 millimeter that was a little bit altered. In that, they said the criteria there said the excessive ST segment elevation should be 25% or more of the QRS complex of the preceding S wave. So the elevation should be about 25% or more of the preceding S wave. So that's what differentiates it from the modified Smith-Gabosa criteria. So this is an ECG representing the Gabosa criteria. As I said, the first deflection we're seeing, there's a concordant one, a concordant ST segment elevation. As I said, the ST segment elevation is positive, the QRS complex is positive. So that's concordant. Why discordant is the second one, the one in the middle. You are seeing the ST segment elevation greater than 5 millimeter up, while the QRS complex amplitude is facing down. So that's discordant. The third one is also concordant because it's a depression, ST segment depression, and also the QRS complex is negatively shown. So that's also concordant. For the cardiac enzymes as a biomarker for patients with acute coronary syndrome, the troponin is a very important enzyme that can also predict mortality and morbidity for this patient, and we can use it to prognosticate. So the values here can also determine mortality at 42 days, 42 days mortality, with values greater than 9 being the highest at 7.5. For the cardiac enzyme, this is a table showing the different kind of cardiac enzymes and when they are detected, when they peak, and also when they start waning away. So myoglobin is the first cardiac enzyme that appears after chest pain. Some books say less than 4 hours, some say within 2 hours, and the duration of detection is as depicted there by 8 hours. it's cleared out from the system. Why CKMB, troponin, they come in they appear in serum within 4 to 6 hours. And for CKMB, by 48 hours, it disappears, or it's cleared from the system. Troponin T and I, they appear by 4 to 6 hours. They peak by about 24 to 48 hours. And for troponin I, by the 10th day, they are cleared out from the system. Why troponin T, it lasts till about 14 days. It is of note that we should note with this cardiac enzyme that the CKMB is the enzyme that is used to determine reinfarction because of the early appearance and the early clearance. About 48 hours is cleared. So it is important that we do serial cardiac enzyme monitoring for patients that present with chest pain, because as we noted earlier, the cardiac enzymes don't appear immediately the chest pain starts. So once a patient comes to the hospital and we do a cardiac enzyme and is negative, it doesn't mean that the patient does not have acute coronary syndrome, STEMI and STEMI. So it's important that we do serial follow-up for these patients. Some books say every 3 hours, 6 hours, 12 hours, 24 hours. With that, you can be sure if a patient has a myocardial damage and release of this enzyme. So when you do it serially, you detect it at the time. On the criteria for making diagnosis for unstable angina, it's a angina pectoris has at least one of the 3 features. So the pain should be present at rest with minimal exertion lasting 10 minutes. It is severe of new onset, or a pain occurring with crescendo pattern. For NSTEMI, the diagnosis is established if a patient with clinical features of unstable angina develops evidence of myocardial necrosis as reflected from the elevated biomarkers. For patients with unstable angina and NSTEMI, the management goal is to either manage them conservatively or with invasive procedures. And this will depend on 3 major factors: the risk of the patient, if the patient has that, the risk of the patient, the TIMI score of the patient, and the risk categorization according to American Heart Association. For the risk of actual ACS, if the patient actually has an ACS, there are different kind of risk classification. If the patient has high likelihood of ACS, intermediate likelihood of ACS, or low likelihood of ACS, as depicted on this diagram. So for a patient with to have high likelihood of ACS, the history is important. There are different variables: the history, the physical examination, the ECG findings, and the serum biomarkers. Once the patient presents with a classic chest pain with the classic radiating areas, having ECG changes of ST segment elevation or T-wave inversion, or having complications like mitral regurgitation, hypotension, diaphoresis, and they do serum biomarkers and they are positive, the likelihood that the patient has this acute coronary syndrome is high. While for intermediate, it has depicted the same classic chest pain, patient more than 50 years, cardiac enzymes are normal, fixed Q waves. When you do an ECG, there are Q waves and T waves and ST segment elevation. These patients, and they don't have those classic complications that patients with ACS have. They just have extra cardiac vascular diseases on physical examination. Those patients are classed as intermediate, while the low likelihood of ACS is on the extreme. You do an ECG, the ECG normal, you do cardiac enzymes, they are normal, but the patient has chest discomfort and also ischemic pain. So those are of the low likelihood of ACS. For the ACS risk criteria, this is a very important risk categorization. This will help us place a patient on the treatment goal. They are divided into high risk, intermediate risk, and low risk. For a patient with high risk, they will have when you do a cardiac enzyme, they have elevated cardiac enzyme. There are ECG changes of ST segment depression. They come with those classic ischemic pain, despite being on therapy. They come with recurrent ischemia with heart failure. They have high risk findings on invasive stress test. depressed systolic left ventricular functions. They come in hemodynamically unstable. We do an ECG, also sustained VT. These patients are patients that have done bypass in the past. And also some of them have done PCR within 6 weeks. You class these patients as high risk. While for intermediate risk, they have pain greater than 10 minutes, rest pain greater than 10 minutes, but on presentation resolved. ECG showing T-wave inversion greater than 2 millimeter, slightly elevated cardiac enzymes. These patients are classed as intermediate risk. While for the low risk patients, their rest pain is usually less than 10 minutes, unlike intermediate, greater than 10 minutes. ECG, not diagnostic. They don't present with symptoms of heart failure, cardiac enzyme normal, age less than 70 years. These are low risk. So based on the categorization of this patient into low, intermediate, and high risk, for the low risk patient, I just treat with the normal anti-ischemic drug, anti-platelet drug. For the intermediate risk, you can also treat conservatively with those drugs. While for high risk must be invasive. You must do your PCI for the high risk patients. But for the intermediate and low risk patients, in as much as you are just managing the symptoms of the patients with the anti-ischemic medications, anti-platelet medications, you should also do a stress test for those patients. If the patient is negative to those stress tests, you continue your management. But if the patient cannot tolerate stress tests, you go back to invasive therapy for those patients. Then for the TIMI scoring system, the TIMI scoring system is a system that is important for patients with unstable angina and also NSTEMI. So it has 7 variables. From these 7 variables, you can use this to also class a patient into low risk, intermediate risk, and high risk. So is that a total of 7 score from 0 to 1 low risk, 2 to 4 intermediate risk, 5 to 7 high risk. You can also, once you risk stratify the patient with these criteria that are depicted on the screen: age greater than 65 years, greater than 3 coronary artery risk factors, use of aspirin in the last 7 days, severe angina, ST segment elevation on the ECG, non-coronary artery disease patient with coronary angiography done with stenosis greater than 50% and elevated cardiac enzymes. Once you stratify with TIMI scoring system, you can also manage the patient as I described, as I mentioned in a previous slide. So for the management of acute coronary syndrome in total, as we said, it is divided into STEMI and NSTEMI and unstable angina. This is a pictorial representation of how this patient should be managed. It's just a very short one that we can look at and understand how we can manage these patients. So we start with unstable angina and NSTEMI. In the acute therapy of the acute treatment of this patient when they present to the emergency, in the acute treatment, as I said earlier, once the patient presents with chest pain, with classic chest pain, we do an ECG for the patient. If the ECG is suggestive of unstable angina or NSTEMI, and we've done our biomarkers, and we have pinned down our diagnosis and excluded other alternative diagnoses, the patient should be placed on continuous cardiac monitoring, placed on oxygen, give your nitroglycerin, give beta blockers, ACE inhibitors, antiplatelets, and anticoagulants. For the maintenance therapy, it is depicted on the diagram by your right. So for the antiplatelet medication, I'll just go through the antiplatelet medications that are used for management of these cases. Acute coronary syndrome patients should be treated with dual antiplatelet agents. Aspirin is the major medication that is used, 75 milligrams to 300 milligrams. When they present in the emergency, we usually start with 300 milligrams to increase absorption. Then continue with 75 milligrams, 75 to 150 milligrams. Antiplatelet like aspirin, they said, will reduce mortality and reduce recurrent myocardial infarction. It is only contraindicated when there's prior aspirin allergy causing angioedema or anaphylaxis. And the second group of drug under the antiplatelets are the thienopyridines. That is where clopidogrel, prasugrel, ticagrelor, ticlopidine those are some of the examples of the thienopyridines. The clopidogrel is held to be clopidogrel be withheld for 5 to 7 days in patients requiring CABG. Then for the glycoprotein 2B3A receptor antagonists, they are used in only high-risk patients. They are not used in intermediate and low-risk patients. Should be used in conjunction with aspirin, clopidogrel, and the low molecular weight heparin. The prototype of this drug is the abscizumab, which is a monoclonal antibody. Other medications under this class are the peptifibatide and the peptidomimetic tirofiban. This slide just shows us the dosages of this medication. Abscizumab, the trade name is Repro. Give a bolus of 250 microgram per kg over 1 minute, followed by IV infusion of 1.5 nanogram per kg per minute. For tirofiban, it is given as 400 nanogram per kg per minute for 30 minutes, followed by IV infusion of 100 nanogram per kg per minute. For peptifibatide, it's a bolus of 180 microgram per kg, followed by IV infusion of 2 milligram per kg per minute. This is the recommendations and the level of evidence of the antiplatelets and the thienopyridine medications that was mentioned earlier. For the first, which is 1A, the 1A evidence, those are strong evidence, and those are the 1A, 1B, 1C, they are strong evidence, and those are strongly recommended for patients with ACS. So aspirin is recommended for all patients without contraindication. While the P2Y12 receptor inhibitors is recommended in addition to aspirin and maintained over 12 months unless there's contraindication to it. But for evidence on that theory, those are a no-no medications or criteria to give to patients. Under the theory, we have treatment with GP2B and 3A antagonists in patients in whom coronary artery is not known or not recommended. Maybe in our leisure time, we can go through this slide. These are just pictorial representation of the antithrombotic agents. On top are the antithrombotic, below are the antiplatelets and their mechanism of action and where they act. For the apixaban, edoxaban, rivaroxaban, as well, know they are factor 10 inhibitors, unfractionated heparin, and bivalirudin and dabigatran are direct thrombin inhibitors. So they block thrombin from activating fibrinogen to fibrin, causing platelet aggregation. So for the antithrombotic treatment, said to be mandatory in all patients with NSTEMI, with or without invasive management. Its choice, the combination, the time point of initiation, and the treatment duration depend on the various intrinsic and extrinsic factors. They should be added to the dual antiplatelet therapy in patients with ACS. For the unfractionated heparin, they require frequent monitoring and adjusted to the APTT level of 1.5 to 2 times the control. The dose is as spelled out there, 60 to 70 units per kg, maximum of 5,000 units, then follow with an infusion of 12 to 15 units per kg per hour, not to exceed 1,000 units per hour. For the low molecular weight heparin, it is as well is superior to unfractionated heparin and can be given subcutaneous and lacks monitoring. Fondaparinux is a synthetic heparin that binds to thrombin, while bivalirudin is a direct thrombin inhibitor. While giving patients these antithrombotic and antiplatelet medication, we should put out the back of our mind that one of the major complications is bleeding. So we must assess this patient for risk of bleeding. And then the Academic Research Consortium for high bleeding risk Academic Research Consortium, they came up with a major and minor criteria for patients that will be placed on the medication for us to ascertain their risk of bleeding. And you just need one major and two minor criteria to ascertain this patient level of risk of bleeding. So the major criteria are as on the slide, they are about 10, 11, while the minor criteria are 6. So we can go through them in our leisure time so we can be fast. having given us the major and minor criteria for patients at risk of bleeding, they also came up with a strategy for us to reduce the risk of bleeding in these patients. So for patients on anticoagulant, it suggested that the anticoagulant dose should be reduced in patients with high risk of bleeding. When doing percutaneous coronary intervention, as we know, we usually can go through the radial artery or the femoral artery. The radial artery is a better vascular site, and it reduces thrombosis and bleeding. So that is the artery of suggested points. Proton pump inhibitors should be added to patients that are placed on dual antiplatelet therapy, and then the others as listed out on the slide. For the anti-ischemic therapy, angina is often associated with inappropriate vasoconstriction and heart rate elevation due to excessive catecholamine release. The aim of this therapy is to alter the hemodynamics and improve the balance between myocardial oxygen demand and supply. All patients with ACS should be on analgesic, nitrates, beta blockers, calcium channel blockers, and statins. For analgesic, the diamorphine or morphine is a drug of choice to be used 2.5 to 5 milligram IV, and metoclopramide 10 milligram IV PRN because of the side effects of the diamorphine or morphine, which is nausea and vomiting. For nitrate, their disease-modifying therapy, they said to reduce preload and afterload, should be used with caution in those with right ventricular infarction and persons on phosphodiesterase 5 inhibitors. The dose is usually 50 milligram and 50 mils of 1 molar saline given at 1 to 10 mils per hour. For beta blockers, they said to reduce myocardial ischemia by blocking circulating catecholamine. Our target heart rate for this patient should be 50 to 60 beats per minute. We will consider in patients with decompensated heart failure, heart blocks, amongst other contraindications. So other choices of medication should be used when patient presents in acute decompensation of heart failure or patients with heart blocks. And the choice that should be started with are the short-acting beta blockers like metoprolol, then later we can convert to longer-acting beta blockers. For plaque stabilization and remodeling, the statins are of utmost importance here, and also the ACE inhibitors, which are routinely used. They are medications that produce plaque stabilization. They improve vascular and myocardial remodeling, and also reduce future cardiovascular events by reducing mortality and recurrent MI. For this anti-ischemic medication, they also have their recommendation and level of evidence 1 and 2. So for the strong level of evidence, which is under class 1, sublingual or IV nitrates or early initiation of beta blocker treatment are recommended in patients with ongoing ischemic symptoms and without contraindication. Also, it is recommended to continue chronic beta blocker therapy unless there are overt heart failure, as I mentioned earlier. For patients with high risk, as we mentioned earlier, invasive therapy is a management of choice. So we don't dwell on disorders, just go straight to invasive therapy. So you are going to the cath lab and managing this patient based on their risk stratification of high risk. So patients, we have two different interventions. We can use for coronary intervention, there are 2 major interventions, the PCI and also for surgical intervention, which is coronary artery bypass graft. But we have criteria in which we can pick which of them we want to use, like patients with single vessel disease, favorable anatomy. Most of them we go with PCI. But when we have occlusion of the left main artery, multiple unfavorable vessels, those kind of patients were advised for coronary artery bypass graft, and patients with diabetes were also advised for coronary bypass graft. Then for management of STEMI patients usually go straight to the cath lab from the emergency room. So the management of STEMI is reperfusion. So once we see a patient with ST segment elevation, the classic chest pain, reperfusion is the management choice. So rapid reperfusion is the cornerstone of current management of with primary PCI or thrombolysis being the main modalities. Early successful reperfusion limits infarct size, improves left ventricular dysfunction and survival. The current guideline recommend goal of door to balloon time of 90 minutes and door to needle time of 30 minutes, with the best long-term outcome being achieved with primary PCI. Well, it is of note that the goal for door to balloon time is 90 minutes. But in a situation where the center maybe does not have the capacity to do a PCI, but there's a referral center they can take the patient to, it is further extended by another 30 minutes, making 120 minutes. So for a situation where instead of using thrombolysis, if the center does not have capacity to do a PCI, but if they have a referral center they can go to and they can make it in less than 120 minutes, those set of patients can also be candidate for primary PCI, unless there are nowhere close around where these patients can have a primary PCI. Then thrombolysis is now a drug of a choice management if they can also get that. So when a patient presents, the acute or initial management, place on cardiac monitor, pass an IV access for your medications, give oxygen, supplemental oxygen, give nitrites, morphine for the pain, and the other anti-ischemic medication. For percutaneous intervention, the PCI is a process of dilating coronary artery stenosis by introducing an inflatable balloon or metallic stent into the arterial circulation via the femoral, radial, or brachial artery. As we said earlier, the brachial artery is the choice site of entry. Primary PCI is the current gold standard for reperfusion strategy for treatment of STEMI. The relative benefits of primary PCI are greatest in patients at highest risk, including those with cardiogenic shock, right ventricular infarction, large anterior MI, and increasing age. It requires significant coordination between emergency service, referral units, and the invasive center. Indication of primary PCI. All patients with chest pain, as we said, and ST segment elevation on new left bundle branch block. Patients where thrombolysis is contraindicated and where there's significant risk of significant bleed. Patients undergoing PCI should be given dual antiplatelets therapy with aspirin and an ADP receptor blocker such as prasugrel and ticagrelor. Anticoagulant options for these patients are also anticoagulants are also important for these patients, which we give the example stated earlier, fractionated heparin and so on. For PCI, the complications, they are also complicated. They are not without its complications and consequence effects. The complications are majorly bleeding, hematoma, dissection, and pseudoaneurysm from the arterial puncture site. Other complications can still be acute MI, stroke, and death. For the PCI, as we said earlier, for stenting, it could be either angioplasty or passing a stent. For the stent, it could be there are bare metal stents and drug-eluting stents. For the bare metal stent, they are associated with a 20 to 30% risk of coronary artery stenosis within 6 to 9 months of implantation. They may be preferred in patients requiring anticoagulation and early surgery. While the drug-eluting stent, they have two generations, the first generation and second generation. The first generation is a sirolimus and paclitaxel, and they reduce this restenosis that the bare metal stents are known for. But these patients have their own complications. They suffer from late stent thrombosis. The second generation is the second generation drug-eluting stents. They demonstrate better safety and efficacy and are recommended for most patients as forgotten the example of the second generation. If I remember, I'll mention it later. Well, I saw this slide and I had to put it, I didn't understand the slide. So I put up the slide so that anybody that can assist me with understanding the slide will also share his knowledge with us. So that's why I put in these two slides, because I don't have clear understanding about them. For thrombolysis, the fibrinolytic agent enhances the breakdown of occlusive thrombosis by the activation of plasminogen to form plasmin. Fibrinolysis is still used if PCI is unavailable. Time is a critical determinant in its success. Treatment within an hour from onset of chest pain have a 50% reduction in mortality, while more than 12 hours derive little benefit. It's also of note that for every 1 hour gain from chest pain to institution of thrombolysis, 1%, there's 1% reduction in mortality for every 1 hour gain, 1% reduction in mortality. For patients who fail to reperfuse by 60 to 90 minutes, as demonstrated by 50% resolution of the ST segment elevation, a rescue PCI is superior to a repeat thrombolysis. Aspirin and clopidogrel are recommended in patients undergoing fibrinolysis. Anticoagulant options are also there, which are the unfractionated enoxaparin and fondaparinux. There are indications for thrombolysis also, as there are indications for PCI. So the indications are patients presenting with typical chest pain within 12 hours and ST segment elevation in contiguous leads, cardiac pain with near or presumed left bundle branch block. Thrombolysis should not be given if ECG is normal or isolated ST segment elevation, or ST segment elevation with no preceding chest pain, preceding history of cardiac pain. Patients with greatest benefit from thrombolytic agents are patients with anterior infarct, marked ST segment elevation, age greater than 75 years, impaired left ventricular function or left bundle branch block, systolic blood pressure less than 100 millimeters of mercury, then presentation within 1 hour of onset of chest pain. Complications include bleeding, hypotension, allergic reaction to streptokinase, intracranial hemorrhage, reperfusion, arrhythmias, and systemic embolization. Contraindications, the contraindication could be absolute or relative. I won't spend much time on them. These are the absolute contraindications, as we all know, and also the relative contraindications. The doses of the thrombolytic agents, I also added them. For streptokinase, give 1.5 million units in 100 ml of saline over 1 hour. For retinoids, give a bolus of 10 units in 10 minutes apart. For anistreptase, give a bolus of IV of 30 milligram over 2 to 5 minutes. For alteplase, 15 milligram bolus IV, then 0.75 milligram per kg over 30 minutes, not to exceed 50 milligram, and maintain over the next 60 minutes with 0.5 milligram per kg. For tenecteplase, you give the injection over 10 seconds at 30 to 50 milligram of body weight, maximum dose of 50 milligram. Then the second option of intervention, which is a coronary artery bypass surgery, as we mentioned earlier, here an autologous vein or artery is anastomosed to the ascending aorta. Anastomosing the ascending aorta to the native coronary artery distal to the area of stenosis. Improved graft survival can be obtained with in situ intermammary artery or gastropolic artery grafted onto the stenosed coronary artery. In different trials that were done that compared the efficacy of CABG over medical therapy, the coronary artery bypass graft were found to significantly improve angina symptoms and exercise capacity and reduce the need for anti-angina therapy. Operative mortality is well below 1%. It is recommended in patients with triple vessel disease and impaired left ventricular function, and also for patients that present with complications of myocardial infarction like VSD and mitral regurgitation. The complications of myocardial infarction are listed below. Most patients, some of the complications include heart failure, which are classified according to KILIP 1, 2, 3, and 4, with their different mortality rates of KILIP 1, 6% in 30 days, with the extreme of cardiogenic shock, which is KILIP 4 at 81%. Some patients can also present with myocardial rupture and aneurysmal dilatation. For rupture of the free wall of the left ventricle is usually an early catastrophic and fatal event. The patient will have an hemodynamic collapse, then an electromechanical arrest. A subacute rupture may allow for pericardiocentesis followed by surgical repair of the rupture. Some of these patients can also present with aneurysmal formation. Then it is of note that for the myocardial rupture, the myocardial rupture could be the free wall rupture, while the septum rupture. The septum is what gives rise to VSD. While for the free wall rupture, as I stated earlier, it is the most catastrophic mechanical complication of acute MI, and with mortality rate exceeding about 90%. The rupture is said to be associated with large transmural infarction, and it is commoner in elderly and women. Most common location for this rupture is in the anterior and also the lateral distribution of the LAD. For the septal rupture, as we mentioned earlier, as I also mentioned, it's affecting the causing ventricular septal defects, and may occur in 1 to 2% of patients with STEMI, may be associated with delay of failed fibrolysis. Mortality rate is very high in these patients, and an intra-aortic balloon pump or coronary angiography may allow patients to optimize towards surgery. Some of these patients may also present with a mitral regurgitation said to be severe, and there are various mechanisms that could be responsible for the mitral regurgitation. It could be from severe left ventricular dysfunction and dilatation, causing annular dilatation of the valve. When there's inferior wall infarction, also it affects the papillary muscle. It causes papillary muscle dysfunction and also presenting with mitral regurgitation. Then the third mechanism is myocardial infarction of the papillary muscles, producing severe pulmonary edema and cardiogenic shock. Some patients may also present with complications like cardiac arrhythmia, presenting with VT and VF. One of the major complications also are patients presenting with pericarditis, which could be post-MI pericarditis or Dressler syndrome. This is said to occur in about 20% of patients in the first few days following MI, common with anterior MI and high serum cardiac enzyme. The Dressler syndrome is said to be autoimmune response to cardiac damage occurring 2 to 10 weeks after the infarct. And for Dressler syndrome, the classic features of Dressler syndrome, most of the patients they present with pericardial pain, classic pericardial pain, elevated ESRO, pericardial effusion, elevated white blood cell count, and fever. Poor prognostic factor for acute coronary syndrome: increasing age, development of heart failure, associated peripheral vascular disease, reduced systolic blood pressure, Killip class as they progress from 1 to 4, the initial serum creatinine concentration, increased elevated serum creatinine concentration, elevated initial cardiac enzyme, cardiac arrest on heart presentation, and ST segment elevation. And this slide is important for some important information that may help us during ethics section and other discussion. So for patients that have undergone angioplasty, they should go 1 week of driving. For CABG, 4 weeks of driving. For patients with angina, patient present with the angina pain, driving must cease if symptoms occur at rest on the wheel. If there's pacemaker insertion, 1 week of driving. ICD placement if implanted or ventricular arrhythmia, cease driving for 6 months. If prophylactic, cease driving for 1 month. After successful catheter ablation of an arrhythmia, 2 days of driving is the rule. In summary, acute coronary syndrome include unstable angina, NSTEMI, and STEMI. The management guideline focuses on immediate assessment, intervention, risk stratification, rapid reperfusion for STEMI, conservative versus invasive therapy for unstable angina and STEMI. Aggressive attention to secondary prevention must be highlighted. Also, as I said, not all STEMI have ST segment elevation. Particularly, you may see a patient that presents with chest pain and an ECG that is not depicting ST segment elevation. We should never forget patients can also present with posterior MI. patient can, because most of our 12-lead ECG don't show us posterior, those V6, V7, V8, V9. So some patient may present with posterior MI. Posterior MI and the 12-lead ECG, we can have a high index of suspicion if if we see ST segment depression in the anterior leads. ST segment depression in anterior leads, also a large arrow wave in V2, V3 as compared to the others, because arrow wave is supposed to be increasing as the leads go from V1 to V6. There's a progressive increase. But once we see a very large or tall arrow wave in V2, V3, that should give us an high index of suspicion that there may be a posterior STEMI. Not all STEMI present with chest pain, as well said. Some patients may present with atypical symptoms like epigastric pain, diaphoresis, and so on. Rarely, STEMI can be caused by aortic dissection. Hence, do not prematurely anchor on only STEMI on ECG. Think of other things that can cause the STEMI and other alternative diagnosis. Take-home message: early identification of symptom with high index of suspicion is very important. Early diagnosis and referral, then early therapy. These are my references. Thank you.
Thank you very much, Dr. Asore, for your presentation. I hope I got the name this time around. It's an excellent presentation, sir. I don't know, Chief on the platform, questions, comments. There was a part where Dr. Asore was showing the PCI procedure. Maybe it's an LAO or RAO that I want us to actually look at. I'm happy that Chief Okopi is there to help us out. Chief Okopi, sir, good evening, sir.
What was it you were trying to say? Good evening, ma'am. How are you?
Fine, Chief, sir. There's a part on the slide where a picture of maybe LAO or RAO during PCI was shown that we will need help with, sir.
Don't take us through this thing. This is a spider view. This is an LAO caudal of the LAD. So it's just the normal CT coronary angio with the mid to distal LAD being occluded. So I don't think there's anything weird.
What about this, sir?
Sir, is it LAO based on us seeing the spine to one side or the other, or how do we identify that if we see it in the exam, sir? Thank you, sir.
Exams, most likely exams, they won't break this. You don't always stress yourself to work. They won't break it in the exam. So if you see the diaphragm, that's a caudal vein. If you don't see the diaphragm, that's more of cranial view because of how the beam is projected from below. And then right, the spine is right, left, the spine is left. It's just the normal thing that Prof has taught us before. But practically, these things will come out in exams. Prof doesn't bring them because he likes to be objective. And since it is not in most centers, he wouldn't bring them. He won't see it in exams. It's only for those, moreover, the pictures are not really dynamic pictures for you to really get a better understanding of it. It just shows you here that there are occlusions. And for a CT coronary angio, we should just pick one or two pictures to put here for us. But in general terms, Chief Asore, I must say that I don't know how to say it, but thank you so much. It took a whole lot of time to prepare this slide. It shows the commitment, it shows the dedication, it shows the willingness to make it easy for the people going for exam, that no matter where they are throwing the questions from MCQ, they will get it clearly. In fact, while we were presenting, I was seeing some of the MCQ questions they asked us during our exams. as though you were in the exam hall. So I must say thank you so much. Thank you so much. Quite excellent and very detailed presentation. Thank you, sir.
Thank you, sir.
I think this your slide should be on the page, right? So that people would consume it both for clinical practice and for others, because really it was quite detailed. It has a whole lot of information. Thank you so much. And then Prof took us a presentation. I don't know, maybe Kwechi will soon put it on CT coronary angio. At least we've been able to access the video. So these images, these static images you just placed now, he explained everything, how to identify the position. Maybe I'll reach out to Kwechi. When you upload it on the YouTube, I'll encourage every one of us to go through it. But really, Prof will not ask it an example. You won't see it. Then when we're preparing, we over-prepared. When then nothing, it was basics. In fact, there was a question on phonocardiogram. That question, most of us just skipped it. That was my first time of seeing it. So I don't know. We couldn't even recall it for you guys. But there was a question on phonocardiogram. You drew some kind of images. So maybe I just remember from this presentation, somebody mentioned something about phonocardiogram. So Prof brought a question on that, but there was nothing. It doesn't go this deep. And then cardiac transplant. I forgot. I don't know if we put cardiac transplant on the curriculum. The Prof asked about the last from 185 to 192 or so. They were all advanced cardiac care and cardiac transplant questions that he asked us in our papers. So, and we couldn't recall it detailed because most people didn't get to that point of the questions during the exam. So I think we also need a very good presentation like this on cardiac transplant. So I think that's for me. If there are more, I'll be around to add more. Thank you so much.
Thank you.
Thank you very much, Chief.
Okay, that's also
Thank you,
over
sir.
to
Adeyanju, go ahead, Jare.
let's go and take water.
Please, can you pause the recording for now so that we can easily... Okay,
Yeah,
Ruki has a question.
Make a comment or question.
Yeah. Good evening, and thank you again for the extensive presentation. Mine is just a contribution on the atypical presentation. Now, the usual history we're given of angina, central or retrosternal chest pain, crushing, radiating to the left jaw or arm with blah, blah, blah. That whole description is the description of typical, features of MI or angina in a middle-aged Caucasian male. Many people outside of this demographic have atypical presentation. Now, because the US is very, very multiracial, data from the US has given quite shed light on how, Blacks, Hispanics, Asians present with MI differently from Caucasians or whites. And so groups that have atypical presentation include Blacks, so pretty much all of us in Nigeria, females. So one needs to have a high index of suspicion in females, including middle-aged females, not necessarily postmenopausal, elderly, patients with DM because they can be painless, patients on analgesics for some other condition, patients with CKD. So we need to have a high index of suspicion for this. And some of the atypical presentations, apart from pain, retrosternal pain could be epigastric pain. So peptic ulcer or dyspepsia is a very strong differential for MI or ACS in a patient who has risk factors. So an obese person with hypertension or diabetes or dyslipidemia or peripheral artery disease comes with epigastric pain. Like look for MI, not PUD. A lot of patients get treated for PUD for quite a while before they come down with complications. Second common atypical presentation, nausea, vomiting without the pain, sudden diaphoresis, sudden profound body weakness that is unexplained. A patient just wakes up, they're severely weak, they can't stand up, they're almost prostrated, and one can't find the reason. Think of MI. Some of these, from what we see in AKHH, because if we look at the race registry of acute coronary events in Nigeria, the incidence of ACS was almost twice in the north compared to the south. So almost every call, there's an ACS patient in our hospital. So just to look out for some of these atypical presentation in our patients, because we're Black, we wouldn't have that textbook description. Some might, but many will not. And then in elderly and female, especially patients with DM. So thank you. So please, PUD in a patient with cardiovascular risk factors. Think MI. Thank you.
Thank you.
Dr. Ozoke, are you on or not?
Go ahead, Andrew.
All right, thank you, sir. Please, is there any other comment or contribution as regards the presentation? In the absence of further comment, once again, Dr. Asore, thank you so much, so much. We are indeed very grateful. Thank you, sir.
Thank you, ma'am.
Thank you, Dr. Adeyanju. You just sent me a message on WhatsApp. Sorry,
Yes.
this is an oversight. So it's an oversight. We didn't put cardiac transplant. We will need someone to help us volunteer. Advanced cardiac care and cardiac transplant. It's a major topic. At least I saw 10 questions from there. Most people didn't reach there during the exam. 10. Very clean 10 sweet questions. And they are quite applied. So we need someone to give us a presentation on. Hey, Dr. John is here. Hello, sir. I don't know if you reached that part of this thing. So that you can also tell us the experience. He brought a lot of advanced cardiac care. Part of the curriculum he was suggesting at NCS was towards all this advanced cardiac care. So, and we saw a couple of questions there, about 10 of them from 186 or something towards the ending. So we want to plead, if there's anybody that can suggest, meet me, you can private chat me for us to just include your name for those going for exams, please. In the recall, we didn't recall it. Most of the recall we did, there was no cardiac transplant recall because most times people didn't reach that part of the questions. By the time they say time up, you'll be around. Me, actually, I finished because I was a little bit fast, but I couldn't remember the terrain. Most times, when they're saying time up, you're around 180, 185. So he now loaded that, and they were quite simple. That was the interesting thing. So is there anybody that can suggest or just help us to cardiac transplant? If you're not going for this October, if you're not going for March, you can just help us, please. Dr. Charles Okori, are you going for March?
No, Chief, I'm not going for March.
Please, sir, can you help us with advanced cardiac transplant? So that those going for March and have it.
Okay, no problem. But you guys, you give me some time, but it's okay, I will do it.
Yes, maybe first week of March, if it's possible.
No, it's fine. First week of March, is it?
All right, thank you so much. I'm grateful. And again, thank you again, Dr. Asore. Very impressive, I must say. In fact, if I didn't recall the MCQ, you would have answered a whole lot of the MCQ question on ACS. And just the way I said, there are key high yield areas you must see in the exam. ACS is one of them. You must see it. You must. If I can advise, the slides of Asore is better to just consume it and consume it in depth. Thank you so much. I'm grateful. Thank you, Dr. Charles, for accepting. We'll wait for first week of March. Thank you.
Thank you very much, Chief. Thank you once again, Dr. Charles. Dr. Asore, please can you kindly unshare your screen? Thank you. We will proceed to the next phase of the discussion. Please, Dr. Olalekan, can you help us share the question? Is it possible, sir? The alphabetical order, well-numbered question. Thank you. Please, we also need a backup for recording because Sawa made that request. The battery of the system might go off soon, so we need a backup for recording.
Sorry, Ade, I think the current recorder should be able to stop the recording so that it will be easier to take this lecture differently than the outside the MCQ.